Okay, well, good morning, everybody. Everybody in this room and everybody who is joining virtually. This is our first hybrid meeting and making progress. It's my great pleasure to introduce the first speaker for this GVHD section of the program. And everybody, welcome back to this GVHD symposia. This is number 10, so it's a 10th anniversary. It's my great pleasure to introduce the first great speaker. Just to mention that, so for the scientific program, please be engaged, think about where, in addition to the main topic, like what the questions could be. So maybe you have some time for a question or two. And then like, where are we going with the chronic and any GVHD in the future? So what does it mean for the next stage? Because it's clearly still much work to be done. Our first presenter is Dr. Mary Bleakley. And Dr. Bleakley is a transplantation and cellular therapy physician scientist at the Fred Hutchinson Cancer Research Center in Seattle. Her team focuses on the development and evaluation of T-cell immunotherapy and graft engineering strategies for hematologic disorders and pediatric cancers. The great work has been going on of Dr. Bleakley, as well in collaboration with Dr. Shlomchik, developing strategies for engineering stem cells to reduce GVHD after allogeneic hematopoietic stem cell transplantation, hopefully eliminating GVHD in a significant form. So the topic of Dr. Bleakley's talk is naive T cell depletion for GVHD mitigation. Please, Mary, thanks for joining.
Good morning, everyone. Thank you for that nice introduction. Just want to thank the organizers for inviting me to speak with you today. Just a couple of disclosures to start with. So Miltenyi Biotech partially supporting a multi-center trial of the GVHD reduction strategy that I'll talk to you about, and I have spoken at a number of symposiums for them. I'm also a scientific advisor to Orca Biotech, who also develops graft engineering strategies. Okay, as you're aware, T cells have both beneficial and detrimental effects in allogeneic hematopoietic stem cell transplantation, including the positive effects on engraftment, a immune-mediated graft versus leukemia effect, and protection from infection. However, the detrimental effects in being central to the pathogenesis of graft versus host disease are very significant. And people have developed various approaches to taming the T cells after transplantation for this reason. That includes pharmacological immunosuppression, in vivo T cell suppression / depletion with strategies like post-transplant cyclophosphamide, and ex vivo pan T cell depletion. As you'll be aware, pan T cell depletion is very effective in reducing graft versus host disease, but is associated with poor immune reconstitution and increased risk of serious opportunistic infections, which increases transplant-related mortality. Because of these shortcomings and because we're very interested in development of strategies to add back cells to reduce the risk of relapse after transplantation, we started to explore a selective approach to removing T cells from the stem cell graft in order to optimize the platform for post-transplant immunotherapy and reduce deleterious graft versus host disease. So a selective T cell depletion strategy really should aim to get rid of the problems and keep the benefits of T cells. So what we're aiming to do is to reduce the graft versus host disease that causes harm to patients. So corticosteroid resistant or dependent acute graft-versus-host disease and chronic graft-versus-host disease that requires systemic immunosuppression. We want to keep the T cells that protect a patient from infections and maintain a positive graft versus leukemia effect and create a platform for introducing more beneficial T cells. So we've been exploring this particular procedure called naive T cell depletion for a while. So as you're aware, T cells can be divided up into various categories, and one way of thinking about them is dividing them into naive, antigen inexperienced T cells and the group of T cells that fall under the category of memory or effector cells. Naive T cells, by definition, are antigen inexperienced. They have a very broad T cell repertoire, and that repertoire is likely to include cells that are specific for minor histocompatibility antigens, which are the molecular targets of alloreactive T cells in HLA-matched transplantation. Memory T cells, on the other hand, cells that have encountered their cognate antigen, mostly pathogens, and therefore consist of oligoclonal expansions of T cells against those pathogens and have a more restricted T cell repertoire. From the basic concepts of who the cells are and what they do came the hypothesis that naive T cells are more likely to cause serious graft-versus-host disease. And that hypothesis was tested by a number of labs across the states in a variety of murine models in the 2000s. And in those studies, which were conducted by several investigators, including my collaborator Warren Schlomczyk, sorry. The studies showed consistently that naive T cells cause severe graft-versus-host disease in murine models. Effector T cells, effector memory T cells do not, and central memory T cells occasionally do cause some milder graft-versus-host disease, but that was dependent on the particular model and the lab, so more variable. But the consistent finding was that naive T cells really do consistently cause severe graft-versus-host disease. We looked at the potential to translate this to humans and specifically studied human cells using HLA-matched siblings, where one would be the T cell donor and one would be the antigen-presenting cell donor. And in those studies performed in vitro, we saw that, again, consistently, the naive T cell population was enriched for minor antigen-specific T cells and had at least 10-fold more minor antigen-specific T cells than the memory compartment. And that informed the development of a strategy for depleting naive T cells from the stem cell graft. And you can see in the left-hand section, the basic idea where usually we have, when we give a stem cell graft, we give the stem cells and all the lymphocytes. Or you can go to the far extreme and just give the stem cells. But in naive T cell depletion, we're going to give the stem cells and the memory T cells that can protect the individual against pathogens, but not the naive T cells. So that the way that we remove naive T cell from stem cell grafts is using antibody conjugated immunomagnetic beads targeting CD45 RA, and CD45 is a protein tyrosine phosphatase, which has 2 molecular weight versions. The high molecular weight version, CD45 RA, is expressed on all naive T cells, and a small population of effector T cells, but not on most memory cells. So you can take out the cells that you don't want or need and leave the memory cell compartment intact. Down the middle bottom of the slide, you can see a little schematic with the CD45 RA positive cells on the y-axis and CD45 RO corresponding to memory cells on the x-axis. And so the naive T cells sit up in the upper right-hand side. And just below that, there's two representative flow plots where you can see antigen-specific T cells that are bound with tetramer overlaying the bulk population. On the very far right-hand bottom shows cells that are specific for a male minor histocompatibility antigen encoded on the Y chromosome, we refer to as SMCY, and those cells are predominantly in that upper right naive compartment, whereas one across the EBV specific T cells are predominantly located in the CD45RO compartment with just a few that are RA positive. So you can take out those cells that are specific for minor antigens and leave those that are specific for the pathogen. Upper middle just shows the schematic of the monoclonal antibody immunomagnetic bead binding the RA molecule on the naive T cells. And going across shows the very strong ability to remove the naive T cells using that reagent. So we then developed a schematic for removing the naive T cells from the graft. So we would first select CD34 cells, which are enriched for hematopoietic stem cells, and put them aside so that we could give it a fixed dose of stem cells and sort of control the T cell compartment independently. From the 34 negative cells, we then depleted CD45RA and then took a fixed aliquot of 10 million RA depleted memory T cells per kilogram as the target. So the cells are given as a single bag of stem cells, followed by the bag of the memory T cells. In the far left-hand corner shows the pathogen-specific T cells in the grafts before, and on the far left after the naive T cell depletion. And the upper is CMV-specific cells and lower EBV-specific cells. So you can see that they're retained in the RA-depleted graft. And in some work that I'm not showing this morning, we were able to show that those cells remain functional and proliferate and secrete cytokines. So after that preclinical work, we've gone on to perform 3 single-arm clinical trials to evaluate a naive T cell depletion of peripheral stem cell grafts as an approach to reducing serious graft versus host disease in patients with acute leukemias and related conditions. And this work was published in JCO last year. So 3 clinical trials. On the top row was the first trial we performed in recipients of HLA match-related donor transplantation. And that was 41 patients. The idea of doing it in match-related donors was when the graft engineering strategy was new, we wanted the donor on site so that if we had any technical difficulties, we could get another collection. Technical aspects went very well, and we didn't actually have any repeat collections or significant difficulties. In that first trial, we also chose to use a very myeloablative high-intensity conditioning strategy to make sure that we could consistently get engraftment, and that's always a question when you're manipulating grafts and taking out T cells. But again, the engraftment has been really reliable. We chose tacrolimus monotherapy for that trial. The second trial was in pediatrics, and that was our first investigation that involved grafts from matched unrelated donors. And we chose kids, A, because I'm a pediatric oncologist, and B, because in that setting, we had a small patient and unrelated donor graft. So we were able to split the graft, split the peripheral blood stem cell product and put half aside for safekeeping, and then do the manipulation on the other half again as a safety measure. But that also went well because it was unrelated donor with potentially a bit more alloreactivity. We added back in some methotrexate, and we used the same high-intensity conditioning. Then the third trial was a larger study on adults and some pediatric patients. And in that one, we had both related and unrelated. And we also, for the first time, were exploring a lower intensity, basically an intermediate intensity conditioning for patients that were older and or had comorbidities. And again, in that the arm of the trial, we found that the engraftment was just fine if you reduce the intensity. There were 7 patients on the third trial where the donors didn't mobilize adequately to do the graft engineering. We had some sort of preset criteria for how much we needed to start the cell selections. And so there's a population of 7 patients that received replete grafts that kind of act as controls for that trial. So the 138 patients that received naive T cell depletion are described here. The median age is 37 years. Roughly half of them had ALL and the other had myeloid malignancies. About 60% were first complete remission without any evidence of residual disease going into transplant. About half of them were HLA matched, and then the conditioning was 2/3 high intensity. This shows the characteristics of the graft. So we consistently obtained above the target number of CD34 cells that we were after, with a median of 8 million per kilo. And we do cap it around 10 million per kilo for consistency. In more than 95% of the cases, we got the target number of total memory T cells that we were looking for, of 10 million per kilo. And then we had a sort of a upper threshold that we're looking for of less than 75,000 naive T cells per kilo, sort of residual in both of the fractions. And we mostly get at least a log lower than that, so 2,500 per kilo typically. And you can see the multi-log reduction in the naive T cells shown in the lower left figure. And those grafts are consistently able to get neutrophil engraftment at a median of 15 days. Okay, so the big question was, would this strategy lead to lower rates of graft versus host disease? And so what we saw was really encouraging and interesting. In the upper right, you can see that the rate of grade 3 graft versus host disease was very low at 4%, and we saw no grade 4 in any of the 138 patients. Upper left, chronic graft versus host disease is also very low, at around 7%. And of that, all but one was mild, with one moderate chronic graft versus host disease in the whole cohort. Lower right-hand side, you can see that despite having very low serious graft versus host disease, we do still consistently have a relatively normal for our institution rate of grade 2, stage 1 upper gastrointestinal graft versus host disease. So this is stomach GVHD, and patients are mostly complaining of early satiety and discomfort. They definitely have some apoptotic cells in biopsies, and most of the patients were biopsied, but no clear lymphocytic infiltrate or tissue destruction. A small minority of them also had some lower GI GVHD, but both upper and lower are very steroid responsive. A minority also have some skin GVHD rash. So the interesting thing about that graft versus host disease that remains is that it was significantly associated with lower rates of relapse and lower death rates. So the patients that got some GVHD did better than others, and that appears to be true however you slice the data, and includes patients that go into transplant with measurable residual disease. So this observation suggests that there is a graft versus leukemia effect that's retained in the naive T cell depleted grafts, and sort of begs the question of how is this working? So overall outcomes have been very encouraging in these trials. The relapse is 23%, which is pretty typical for transplantation of patients with acute leukemia. Non-relapse mortality is 8%, and we haven't been seeing deaths from opportunistic infection. The overall survival, 77%, and the severe or chronic GVHD relapse-free survival is around 64%, and that is approximately twice what you expect in T-cell replete transplantation. Again, a summary slide looking at the chronic GVHD relapse-free survival, which is essentially identical in HLA-matched related and unrelated donors. In terms of infection, we see approximately the same rates of opportunistic infection as you see in T-replete transplantation, with less than 1 to 2% rates of significant EBV reactivation, HHV6 or adenovirus. CMV reactivation is 12% to significant levels, and that's comparable to the literature on T-replete transplantation. This slide summarizes what we see in terms of lymphocyte reconstitution. And the naive T-cell depleted recipients are depicted in teal. A handful of patients that are receiving post-transplant cyclophosphamide on our current clinical trial, randomized trial, are shown in pink, and then patients that receive T-replete grafts are in orange. And what you can observe is that in the early post-transplant period, both a naive depleted recipients and the PT-Cy are comparable and somewhat lower than the T-cell replete recipients, but that difference decreases over time. And you can see the differences both if you consider overall T-cells, CD8s, and to a slightly greater extent CD4s. Tregs are also a little lower. The opposite is true for NK cells, which are higher in naive depleted recipients early post-transplant. Along the bottom row, you can see that the naive T cells are, as you would expect, very low in the naive depleted recipients. Also, interestingly, somewhat low in the PT-Cy recipients. And with the naive T-cell depleted recipients, that starts to correct around 6 months after transplant, and younger patients have a fair amount of recovery by a year. Older patients do recover naive T cells, but it takes a little bit longer. And the B cells are low early post-transplant in essentially all transplant conditions and recover by about day 90. So we are looking at the lymphocyte landscape after naive depleted transplantation in a little bit more of a nuanced way, and I've got a little bit of data in progress. So what we're doing is studying the stem cell grafts before and after depletion, and then looking at cells recovered from the patients at 5 time points post-transplantation. We are looking at it in a sort of traditional Boolean gating way, and also using an unbiased clustering method to look at the various patterns. And we're asking 2 basic questions. One is, how does the lymphocyte landscape look in naive depleted recipients compared to other transplant platforms? And secondly, within the naive T-cell depleted patients, what lymphocyte patterns associate with clinical outcomes? So just a really small example. Up on the left-hand side is the bubble plots show a representative CD8 panel that we're looking at with various T-cell markers along the bottom. And with the unbiased clustering, a number of clusters can be identified, and those unbiased method basically separates them into what we understand to be traditional T-cell subsets, and separates them with with and without activation. So from the bottom, we see naive T cells, central memory T cells, activated central memory T cells, and then activated effector memory T cells. If you look at the UMAPs on the upper right-hand side, with 47 naive T cell depleted recipients along the top and 20 T cell replete controls, the couple of things are obvious and made more so in the circles. So in the blue circles are the naive T cells. And as you can see in the T cell replete patients along the bottom, you can see them throughout the post-transplant period. But in the top, they're essentially missing early on and then start to recover at day 180 and beyond. Also different is at the top in the black are the TEMRA cells. So the RA positive effector T cells are again missing largely from the naive T cell depleted recipients. So all of that is pretty predictable from the graft engineering strategy. But what we were a little surprised and interested to see is that shown in the box plots down the bottom, the blue are the naive T cell depleted recipients and the maroon are the replete. And you can see that the naive T cell recipients have much higher frequencies, both in relative and absolute terms, of activated T cells, particularly early post-transplant. And if you do the calculations, the ratios of the activated T cells to the T regulatory cells is really very high. So there's quite a lot going on in their T cell compartment in that first 100 days. We have similar data for CD4 T cells, NK cells, and B cells. I'm not going to show you all of it, but both for 8s and 4s, we're seeing the activated T cells, and the NK cells are also more frequent in the naive T cell depleted recipients. The data isn't ready to share today, but we have been exploring those associations between outcomes and the lymphocyte landscape, and we've recently had quite an interesting finding in identifying a effector memory CD4 population that seems to associate with acute GVHD and possibly from protection from relapse. But we need to do quite a lot more work to replicate and validate that finding. So in conclusion about the single arm trials, so we've pretty clearly established that this approach is feasible, that we can do it with HLA matched related and unrelated donors with various conditioning, and we've recently added a busulfan-based conditioning to the possibilities as well. We're seeing a lower incidence of serious acute and very low chronic graft-versus-host disease. We also see that recipients of naive T cell depletion require a shorter duration of immunosuppression, which does mean that people that recur are more likely to be able to receive donor lymphocyte infusion or more sophisticated cell therapies. We don't appear to have an increase in relapse, and that might be that it is associated with the milder graft-versus-host disease, and we may have some leads as how that's operating. I just want to mention we have the single-arm data is all very good, but until you can randomize and directly compare, you really don't know the risks and benefits for procedure. So we've initiated 2 randomized control trials to do just that. We have a pediatric multi-center trial in progress, approximately half the way through accrual. That trial randomizes naive T cell depleted transplantation against standard unmanipulated bone marrow transplantation for children and adolescents with acute leukemias. It's open at 8 to 9 centers across the states, and hopefully it will complete in the next 18 months. We also have a predominantly adult trial that has been funded by the NIH. We're comparing naive T cell depleted peripheral blood stem cell transplant with PBSC and post-transplant cyclophosphamide as the emerging standard of care in adult transplantation. That is 120 patients, and it's open at 3 centers at the moment, and is about 25% of the way through accrual now. So hopefully we'll get done in the next 2 to 3 years. With that, I need to acknowledge that this all takes a village, and there are many, many people who have contributed to the work over time, and very importantly, our patients that choose to participate in new approaches. Also, we've been very lucky to enjoy a variety of funding over the years that have kept these academic trials going. So thank you also for your attention, and I'm happy to take any questions. So are we studying the tissues in the recipients of naive T cell depletion?
Yeah.
Yeah, so we have biopsies from the stomach in about 50 patients, and they've been studied usually using standard H&E methods. You can see consistently that patients that get stomach GVHD after naive T cell depletion have a few apoptotic cells. They're graded usually as minimal to mild. We don't see a lymphocyte infiltrate, but as you know, as we work through the correlative assays, we will likely do some more sophisticated IHC and possibly spatial transcriptomics, et cetera, to study those tissues and understand what the populations there are. There aren't really other tissues to study in that, you know,
I'm wondering.
The stomach and the marrow is really the places to be looking in addition to the blood.
Yeah, I'm wondering which subtype of the mammary T cell in there. Maybe different, not the central mammary, maybe it's different. Okay.
Yeah.
Sure. Molly Gologly from University Hospitals in Cleveland. I might have missed this and you may have explained it, but do you know why in the patients receiving these naive T cell depleted grafts, you would still have some upper GI GVHD and not the other types? Is there something about the tissue or the signaling going on where that still persists?
That's a great question, and when we're doing a fair bit of work to figure out, it is quite possible that one of the memory T cell or effector memory T cell compartments is contributing to the milder GVHD that we're seeing. If it may be that it's not a directly alloreactive population, but a population that's specifically seeing pathogens and or microbiome and is just active and secreting cytokines. It might also be that because it's a more differentiated cell population to start with, that they're not really able to establish the clones that you need to maintain a severe phenotype of GVHD. So, you know, when we deliberately transfer T cells for anti-leukemic activity, the younger the cells you give, if you give naive T cells or central memory T cells, they have much greater ability to persist. But if you're giving an effective population, they sort of do their thing and die out quickly. And so maybe that's part of the difference.
Yeah.
Hi, I'm Teresa Magon from NIH. I had a question. I'm an ophthalmologist, whether you observed milder cases of ocular GVHD, or if you could comment at all on in your trials.
Yeah, so a few of our patients have dry eyes and are counted in the mild chronic GVHD group. Some of them might not even actually be GVHD, they might just be dry eyes, but we count everybody that, you know, fits by NIH criteria. We've never had anything more severe than that.
Hi, this is Hanacha from Ohio State. I was wondering, you had mentioned that there was an increase in the NK cell population early. Do you have hypothesis as to why that happens with the T naive depletion?
So T cells and NK cells compete for cytokines such as IL-15. So I think if you have, you know, slight lymphopenia from the T cell compartment, then the NK cells just have more fuel to expand. And there are differences also in the lymphocyte landscape after naive depleted transplant according to the CMV status of the patient and the recipient. And we're seeing some quite characteristic patterns in CMV positive. So in the patients that receive grafts from CMV positive donors, some of the NK cells may be acting as anti-pathogen cells and sort of bridging a gap a bit.
That's very interesting. Thank you.
Thanks. Hey, Marie, great talk. Greg Yannick, University of Michigan. You know, it's interesting how you're comparing the results of this to what you see with PT-Sci. You made some comments on that. You know, I was at a talk that Leslie Keene gave the other day on PT-Sci, and she talked about the loss of diversity of the T cell repertoire. She talked about the ablation of NK cells with PT-Sci and how that probably in her mind led to increased relapse rates, some of the secondary infections you see with PT-Sci. From what I've heard, your system works better. You're preserving NK cells. I don't know if you've looked at your T cell receptor or diversity of your T cell repertoire just to see, but it seems like you're still preserving NK cell function, which led to your lower GVL rates, and you're not seeing increased infections. So maybe you're not seeing a loss of diversity of your T cell repertoire. Any thoughts?
We haven't looked at that systematically enough. We certainly see large clonal populations, particularly in the CD8 compartment, particularly in patients that are CMV positive. So we've got expansions. The question is, what is the non-expanded diversity more? I would think it's probably more restricted in the first 6 months, but then people have enough thymic function that they generate new naive T cells, and those new naive T cells are tolerized in the thymus, so they don't react against minor antigens of the recipient, but do over time reconstitute adequate diversity. We'll know what adequate is with time. We follow these patients for 5 years, and we're not seeing increased rates of late infection either. I'm looking pretty closely at the varicella data. There is a significant varicella reactivation. It doesn't look different from the published literature, but the control trials will help us sort of understand that a little bit better.
Marie, hi, I'm sorry I missed your talk. One of my dear first lieutenants gave her first cancer center grand rounds today, so I had to be part of that as a virtual topic, but it will be interesting to see how your T cell repertoire data shake out, particularly in the context of infection. But I did hear my dear friend, Dr. Yannick's comment about data that have been shown about this bottleneck in T cell repertoire. My response to that is maybe that's not a bad thing, because that data comes out of the study that demonstrates that a PT-Sci based regimen is better for graft versus host disease-free, relapse-free survival. So there is no increase in relapse in those patients, at least the match-related and matched unrelated donors. But it is a common, I don't want to say misconception, and yes, I'm here from Hopkins, but I was not born and raised there. But this is an important aspect to kind of dissect further when we think about different approaches to GVHD mitigation. This whole symposium is about graft versus host disease. Wouldn't it be great if we could just get rid of it? Of course, maintain those graft versus leukemia effects. But now that we have your platform, there's of course PT-Cy, there's alpha beta T cell depletion, there's abatacept or abatacept, however people like to say, but understanding how they are all affecting the T cell repertoires is going to be very important. But I will say again, the bottleneck that Dr. Keene points to may not be a bad thing if your outcomes are actually superior. So not to say we can't build upon that, but I think it's going to be a particularly interesting facet of all of this for us to focus on moving forward.
Yeah, I completely agree with you, Dr. Cook, that, you know, it's very important to study things in detail in the lab, including the repertoire, but even more important to collect the clinical data in a detailed and longitudinal way to be able to compare the platforms and what it actually means for patients. And, you know, there are probably pros and cons of all of the platforms. So it's important to take the totality of the data to kind of select the preferred one, but also to understand, you know, what the particular risks and nuances with each platform is, and you know, prepare accordingly, and you know, intervene with vaccination. Or one of the young faculty in our institution is studying zinc in terms of thymic reconstitution, and thymic reconstitution is really important for naive T cell depletion because you've taken out your naive T cell compartment. But what Lorenzo is seeing is that patients, about 25% of transplant candidates are zinc deficient. And when you go into transplant with zinc deficiency, you can again often see that at day 80, and those people reconstitute more slowly. It's very, very simple to give a zinc boost before transplant and augment the reconstitution. So you just need to study things closely enough and figure out what we could do to make the platforms perfect.
From what you've seen so far, with what you're following more long-term for your T-naive depleted patients, are you, is there any thought that there'd be differences in vaccine response?
That is important to study. We're not doing that in a structured way, but it's an area that's very ripe for evaluation.
Thank you.
Hi, Seth Ratz from Cleveland Clinic. The rates of viral reactivation were really low in the data you showed. I was wondering in particular, if you have experience with CMV positive recipients and CMV negative donors, and if anecdotally that was any problem, you know, in terms of reactivation, or, you know, or if you have any anecdotal experience with just bad reactivation that was hard to get under control.
Mostly no, but there are some CMV positive, negative pairings where there were multiple CMV reactivations over time, and occasional people that also developed some cytopenia in that context, where I guess there was too much inflammation going in on their marrow, with, you know, attempts to control the infections that weren't as good. So we prefer CMV positive than positive negative if possible.
Hi, Betty Hamilton from Cleveland Clinic. Quick question. I know overall the rates of both acute and chronic were low, but was there any difference in time to GVHD?
Can I just finish answering the last
Oh,
question?
I'm
And then
sorry.
no, sorry. Letermovir, that's, you know, that's the big answer to CMV, right? And so in the current trials, it doesn't really look like an issue.
I apologize.
No, I apologize. So the acute GVHD tends to happen fairly early. The sort of peak is in day 20 to 30, I think fairly soon after the inflammation associated with conditioning is sort of still active. The chronic GVHD doesn't really seem to be any different in its chronology. It can appear from day 80 to, I think the latest we've seen anybody declared with chronic GVHD is about 2.5 years. Most of it is in the first year.
So I just wondering, so I also from OSU, so, and I just wondering, when you for patient treatment, you still have a stem cell, right? Injections. So how long you observe about half a year, right? So I just wonder if for a long time, it's still possible the stem cell can differentiate to generate the Naïve T cell, or instead of other only memory T,
So we follow these patients for about 5 years, and the young patients do start to generate new naive T cells from their stem cells and progenitors at around day 180. We can see the naive T cells in the blood. We can also see CD31 positive CD4 T cells, and we can look at the T cell repertoire widening at those times. Older patients will do the same thing by about 12 months afterwards.
Thank you. So well, outstanding discussion. Thanks so much, everybody. We're running out of time. Just very quick question. In your randomized trial, I didn't get what was the pharmacologic in the adults? What was the pharmacological prophylaxis in your arm versus PT-Psy?
It's for
Are they the same or what?
For the PT-Psy, it's PT-Psy and tacrolimus. For the naive depletion, it's tacrolimus and mini methotrexate. So 5 milligrams per meter squared times 4.
Okay. Well, thanks very much. Appreciate it. And I think Dr. Hamilton. Oh, it's Dr. Cook is introducing the next speaker, right?